login.
Yes. Good evening, one and all present here. I am Monalisa from Clearnet, the designated session assistant for the seamless interaction. Clearnet is India's most trusted and widely used digitech platform, offers a wide array of enriching services exclusively for doctors. We are very much delighted to be a part as a digital partner for this event organized by Society of Oncoanesthesia and Perioperative Care. And today's session is all about tumor-related pain. Thank you for your patient listening, everyone. So let's get the session underway. And I am delighted to welcome Dr. Goswami ma'am to take the session for. Okay, ma'am.
Okay, thank you, Monalisa. I'm Jyotsna Goswami, right?
Okay. Sorry, ma'am.
Good evening all. So today we are starting the 36th of our webinar series. And today's interesting topic is tumor-related pain. It will be taken by Dr. Ahirup Nayak. And for that, I am inviting Dr. Parneet Suvvari, who is the consultant in the American Hospital, Hyderabad. He will chair the session and he will invite Dr. Ahirup Nayak. Over to Dr. Parneet, please.
Very good evening, all of you, all the panelists and the attendees. Thank you very much for the opportunity. Welcome to all of you for the session today on tumor-related pain. We tried to make a very engaging session today. So today's speaker will be Dr. Ahirup Nayak. He is an associate consultant in the Department of Anesthesia, Pain Management, Perioperative Care in the Medica Super Speciality Hospital, Kolkata, West Bengal. So he's a young consultant with a very learning attitude. So yeah, wish all the best. Over to you, Dr. Ahirup.
Thank you for the kind introduction. Okay, so let's start with the topic. So first of all, we'll give the overview is like we'll go through the definition and what is tumor-related pain, the basic principles of nociception, then the epidemiology of the tumor-related pain or the cancer pain, and the various syndromes that are associated with the cancer pain. Then we'll go with the assessment of the cancer pain, and then we'll go with the treatment. So as per the International Association for Study of Pain, they have revised this definition of pain. So it's an unpleasant sensory and emotional experience that is associated with or resembling that associated with the actual or the potential tissue damage. So they have also further explained it in 6 keynotes, like it's a personal experience, the pain and nociception are different phenomena. Then we should learn from the life experiences, and should always the pain that is the complaint should always be respected, and such many more. So there's a gross classification of pain which can be classified as per whether it's a transient or acute pain or chronic pain which persists more than 3 months, or maybe due to some tissue damage, or maybe physiological or pathological, or this may be nociceptive, inflammatory, neuropathic, or cancer-related pain, may be related to some noxious stimulus or inflammation or damage to the various tissues and the central nervous systems or the peripheral nervous systems. And also this may be because of healing or repair, or maybe due to some protective features. This pain might also be for that reason. Now for tumor-related pain, we can grossly divide it into due to the pain occurring due to the growth of tumor, like mechanical pressure causing on the nerves, the bone, and the organs, and the treatment of pain may be due to the treatment of the tumor related pain. So that may be the post-surgical pain or post-chemotherapy related pain or post-radiation pains. So the mechanism of inflammatory, visceral, and neuropathic pain are quite different from those of acute pain, and the cancer pain may both overlap and differ in some respects with these broad categories. So for the nociception, basically we have various receptors on our peripheries like the skin, and from there are various afferent fibers like the A beta, A delta, and the C fibers, which deal with relaying the information, pain information from the periphery. So as per the myelination, the A beta are the most highly myelinated. They are the maximum conduction velocities, and they carry forward the low threshold and non-noxious information like touch. The A delta are thinly myelinated. They have medium velocities, and they carry forward the non-noxious or the noxious sensory information. The C fibers, which are the least the non-myelinated, they have the least velocities, and they have high threshold for the noxious. They carry forward the noxious uh, stimulus, and these all are they're terminated at the dorsal horn of the spinal cord. Basically, the A beta at the lamina 3 4, the delta at lamina 1, the C fibers at lamina 2. Now, they are also the neurons are also classified as the low threshold or the nociceptive specific or the wide dynamic neurons. Then, if we come to the epidemiology of pain, so cancer pain overall, all worldwide, affects a lot of people, but they're not very well controlled in almost 80 to 90% of the patient. And there are the overall prevalence is between 33 to 50%, and it's more when the disease is at an advanced stage. So these are the various epidemiological data regarding the various cancers, like the head neck cancer is accounts to the most highest prevalence of pain, 80%, genital 77%, esophagus, and so on. So the cancer pain syndrome. So what is a syndromic classification? A syndrome is a constellation of the symptoms, signs, and related findings that together identify clinically recognizable phenomena. Cancer pain syndrome may either be acute or chronic. They are mainly broadly related broadly to the direct effect of the cancer itself, which is about accounts to about 85 to 93%. The complication of cancer treatment like surgery, interventional procedures, chemotherapy, radiotherapy, 17 to 21%, and other factors which are unrelated to the cancer or its therapy. Now, the acute cancer pain, similarly, the pain like acute and chronic cancer syndromes are there. So the acute may be due to complication of disease or therapy or antineoplastic therapy. And in contrast to the chronic pain, the acute pain more often may be related to the iatrogenic factors than to the disease itself. So here are a few charts which I'll be presenting for the like acute pain syndromes associated with the cancer, which may be directly to cancer, like rupture of the hepatocellular carcinoma or pathological fractures or metastasis, or pain related to some infections like herpes zoster, post-herpetic neuralgia, which are the complications of the disease maybe, and the acute pain associated with thrombotic events are also there. So also we have this pain, acute cancer pain may be related to some diagnostic interventions, like if we are doing any lumbar puncture or any bone marrow biopsies, or post-operative acute pain, or due to some percutaneous biliary stains, or also maybe due to analgesic techniques like epidural injection pain may be also there. And also associated with the various cancer therapies that we have, they may also be associated with pain, and there are various pain syndromes associated with that. And then the chronic cancer pain syndromes is may be classified as nociceptive somatic or nociceptive visceral or neuropathic. They may also result from the therapies administered to treat the disease, or from disorders which are unrelated to the disease or its treatment. These are the various chronic pain syndromes that are associated, like bone pain, or many associated with the soft tissues. The bone may be the vertebral metastasis, or the skull mets, or the muscles may be associated. Also, there are paraneoplastic syndromes that lead to the chronic pains. Also, nociceptive visceral pains may be the hepatic distension, the intestinal obstructions, urinary obstruction, like those which are very common. The neuropathic pain syndromes are also there, like the leptomeningeal metastasis, or the painful cranial neuralgias like glossopharyngeal neuralgia, trigeminal neuralgia. Painful radiculopathies are also associated, and paraneoplastic syndromes are also there. Mononeuropathies are also there. And also, there may be pain associated with anti-cancer treatment itself. So maybe due to the chemotherapy, hormonal therapy, or post-operative pain, or post-radiation pain as well. And there is also a segment which is the pain in the cancer survivors, which may also be due to the post-operative pain or post-chemotherapy pain, post-radiation. All this syndromes, all this will be covered in the subsequent lectures. So now we come to the assessment of pain. When a patient comes, how to assess pain? So basically, there will be medical evaluation, physical examination, medical history, and diagnostic tests. The pain severity needs to be assessed by the various scales that we have: the verbal descriptive scales, the visual analog scales, numeric rating scale. Various pain questionnaires may also be used. The pain characteristics needs to be evaluated, like the location of the pain, the temporal pattern, the quality of the pain, or any prior treatment. The impact of pain may be the interference with the daily activities, the quality of life, mood, social support, and concurrent symptoms. Now, this is a in like chart of the interview, which we take the pain history, the locations, intensity, temporal pattern, which I've just explained in the previous slide. So this is a brief pain inventory. Just shown that. And this is the Anderson symptom inventory, which are used for the assessment of various pains. Now, pain is actually, it has to be a multi-dimensional assessment. Pain does not mean only physical pain. Pain has a broader dimension, and a total pain concept is there, which deals with the patient's physical, spiritual, social, and psychological aspects of pain. Now, the various issues or pharmacotherapeutic issues for the assessment of pain are the appropriate opioid dosing, the compliance, the choice of the administration of the route of the opioid, opioid toxicity, the tolerance, and the cross tolerance, and all this needs to be dealt with. And there, because of the various spiritual, social issues and psychological issues, patient also suffer from pain in all these aspects as well. And there are various factors that are associated with the patients in advanced cancer, like patient do have anxiety, adjustment disorder, somatization, depression, chemical coping, and cognitive dysfunction, delirium, and personality disorders are also associated. Now, for treatment, basically what we follow is the WHO analgesic ladder. Initially, it was only a three-step ladder. Now it has been modified. So the for mild pain, like for the pain score of from 1 to 3, we will probably start with a non-opioid plus minus with an adjuvant therapy. When the pain is a bit more like mild to moderate, like from 4 to 6 probably, then a weak opioid with non-opioid or plus minus adjuvant therapy. And when moderate to severe, the strong opioid with non-opioid or adjuvant therapy. Now, the fourth step of the ladder, which has been added now, is the interventional therapies along with the non-opioid or adjuvant therapy. The WHO ladder is such that as per the assessment, as per the scoring of the pain in the patient, we can start with that step of the ladder, and we as the pain increases or decreases, we can move up and down on the ladder. So the various options that we have, most common is the opioid analgesic drugs, which is most effective and most commonly used. Majority of the cancer patients, they pain in 80%. So pain cancers often undiagnosed, inadequately treated with opioid analgesics is well documented. Many factors which influence the pain management of patient groups are inappropriate and suboptimal education of the physicians and other healthcare professionals, which is a major barrier here for the opioid use. And developing countries, we have a reduced availability of opioids and financial limitations, and government regulations have some hindrances in using the opioids. We have also shown the various opioids that we usually use, like morphine, fentanyl, buprenorphine, and their various half-lives are there. And opioid also comes with a lot of side effects, which should be kept in mind, like the sedation, nausea, vomiting, constipation, respiratory depression, and some pruritus, anaphylaxis, sweating, or opioid-induced neurotoxicities are also sometimes associated, like severe sedation, hallucinations, and non-cardiogenic pulmonary edema, immune systems, endocrine functions are also sometimes associated with the side effects. Then next comes after opioids, we come across we use the various antipyretics. Of them, the acetaminophen is the most commonly used. And other than this, we also use the various NSAIDs, the various selective COX-2 inhibitors are also used. Among them important are the celecoxib, the etorecoxib. These are commonly used. And then there are various adjuvant analgesic drugs are also used, like analgesics for multi-purpose analgesics, like the corticosteroids are used. Analgesics for neuropathic pain, like tricyclic antidepressants, the SSRIs and SNRIs that we used. Other antidepressants are also there. Anticonvulsants like GABA, pregabalin, and then carbamazepine and others. And also, other than this, we use analgesics for bone pain like bisphosphonates, calcitonin, and all this. And for any bowel obstruction, we can use scopolamine and octreotide and all. So among the adjuvant analgesics, we commonly use the amitriptyline and the triptyline, and also duloxetine. And for the anticonvulsants that we use are the gabapentin and the pregabalin. And as already told, for the bone pain, we can use among the bisphosphonates, we can use zoledronic acid, and also we use calcitonin. So the neural blockade for the cancer pain. So adequate cancer pain control can be achieved in majority of the patients with the implementation of aggressive pharmacological treatment with opioids and adjuvants. But even with the implementation of strategies, 90 to 95% may achieve adequate pain relief, but again 5 to 10% may need some invasive therapies. Control of pain and its related symptoms is a cornerstone of the cancer treatment and promotes an enhanced quality of life, improved functioning, better compliance, and a way for the patients to focus on the things which give meaning to their life. In addition to the effects of quality of life, mounting evidence is there. They also they have good pain control influences there for the survival in these patients. So, so before going for these interventions, we should assess the performance status of the patient. If the performance status is good, then we can easily go ahead with the interventions. But if the various performance status assessment like Eastern Cooperative Oncology Group or the Karnofsky, this statuses help to assess. If there's very poor performance status, then probably we might think twice before going ahead with some interventions. And this is basically the compiled, both the scales are compiled in a single slide here in this. And then the various neural blockage for the cancer pain. So maybe the intraspinal anesthesia, targeted nerve blocks, or neurolysis can be done. Okay. So the conditions where epidural neural blockade gives a success. This is we to place the tip of the catheter in the dermatome, which is corresponding to the area of nociception. Severe somatic pain, we might combine the local anesthetics and opioid. And for neuropathic pain, if the level is below L3, L4, then the initial therapy would be opioid with clonidine. And if it is above that is above L1 and L2, then opioid with bupivacaine may be used. Then the various nerve block techniques can be used, which is basically can be used as a diagnostic procedure first, followed by therapeutic procedures. And also we can give trigger point injections. Various neurolytic blocks we may use, like the celiac plexus block, superior hypogastric plexus block, ganglion impulse blocks, and neurolysis, like intraspinal neurolysis or peripheral neurolysis. All this may also be used for the treatment of pain. And there are also neurosurgical treatment for the cancer pain, like ablative procedures may be used for the dorsal root entry zone, the cordotomy or myelotomy, and intracranial ablative procedures are also there. Then we also use in our pain interventions, we may also use the intrathecal drug delivery system with pump technology. This is very helpful, helps for the pain of spasticity or following any spinal cord injury or in cases of opioid withdrawal. Then neuroelectric stimulation, we might stimulate the various parts of the brain, the motor cortex, the deep brain, or even spinal cord. And there's a possibility of anatomic as well as chemical approaches to the surgical targets within the forebrain. This is also maybe the thing of future. Then a very important thing is the psychological interventions in cancer pain. Because of the psychological interventions, they actually give support to the patient, and they probably have the better they may have a better life. The pain coping skill training is there. Partner assisted intervention for cancer pain. A comprehensive yoga based interventions can also be there. Hypnosis and guided imagery for the cancer pain. These are also there. There's all this help in the better survival or better coping up with the pain in the cancer patients. And then rehabilitation has its own role here. For there's a prominent tool in cancer pain management, and so the ultimate goal is improving the patient's quality of life. And the various issues that are looked after: skeletal pain, neuropathic pain, soft tissue trigger points, and there may be muscular imbalances or shortening. And the managements are with the various like superficial heat and cold ultrasound, or the transcutaneous electrical stimulation, yoga, tai chi, mind body techniques, music, relaxation, imagery, meditation, and all this, they help.
I can see it. Let's just wait for a while. Maybe some network connection, low network bandwidth is happening from there.
If at all it is, I mean, like I can share my screen and I can do the rest of the presentation. We are running out of time.
Yeah, exactly. I think you can continue till the video comes.
Sure, ma'am.
Praneet, you can, I think, continue. You can start it later.
Give me a minute, ma'am. Yeah.
Later till the video comes.
As mentioned, there is a role of palliative radiotherapy, and all we need to do and refer the patient to palliative before referring to the patient to palliative therapy. We need to assess the status of the cancer, assess the patient's symptoms and function status, also assess the prognosis, which kind of patient you need to refer, assess the current management, assess the feasibility of radiation therapy, and then evaluate the patient's preferences, whether they want to go for radiation or not. As mentioned previously, we need to look at the performance status of the patient, and the patient, if they're terribly bedbound and they are having a poor performance status, let us say a Karnofsky of 10 to 20 and an ECOG PS of 3 to 4, there is no point referring them to further anti-neoplastic therapy. So there are, after going for radiation therapy, now we'll come to chemotherapy. There are many palliative chemotherapeutic agents, and these are the agents which are seen on the left side. I'll just enable my pointer. So the agents which are seen on the left side are the drugs which can be given through oral route, like cyclophosphamide, hydroxyurea, erlotinib, sunitinib, sorafenib, etc. And on the right side are the associated toxicity of various chemotherapeutic agents. So the various toxicities, those who are working in cancer setup must be aware about nausea, vomiting, stomatitis, diarrhea, hepatotoxicity, etc. So the the palliative systemic anti-neoplastic therapy, the drug classes like corticosteroids, estrogens, androgens, progestins, hormonal analogs, anti-androgens, anti-estrogens, they have their specific side effects, which are mentioned here. Not going into much detail here, but coming to cancer pain in children, the cancer pain is a different, is slightly different that the regular WHO analytic ladder pattern is slightly altered here. The step 2 of cancer, step 2 of WHO analytic ladder is not valid in children, because in children less than 12 years of age, we should not be prescribing tramadol and tapentadol, because there are chances that they might be ultra rapid metabolizers, and there can be risk of seizures and accumulation of O-tolerin metabolite. So there are various spectrums of tumor which are quite different from adults. Like they can be leukemias, brain tumors, etc. And they may experience the bone pain, neuropathic pain, and they may have emotional elements. The counseling of the patient along with the parent is very important. And chemotherapy can be continued, are often continued even once cure is unlikely in children. We have seen in our setup very, very commonly, because the parents are not willing to give up on child's. They can't give up very easily. It's a very difficult decision to make for the parents. So as I mentioned, the step 2 of the WHO analytic ladder is omitted in children, because we do not give tramadol and tapentadol for children less than 12 years of age. So coming to the elderly patients more than 70 years, the assessment of older cancer patients is very important. We need to document the history. We need to know their performance status. We need to know their activities of daily living and instrumental activities of daily living, and then assess the family and caregiver distress. There can be multiple stakeholders there. And these patients, they are very much prone to delirium. They are also prone to spiritual distress. And they may have some kind of addictions, and we need to assess how they are doing. So chemical coping in the form of cage questionnaire may be helpful. So as previously also mentioned, the cancer pain has not only got the physical aspect, but any pain as such has a spiritual, psychological, and social aspects as well. So cancer pain is usually it has a chronic nature, and then there can be an associated psychological symptoms as well, and depression can be there. So the psychological symptoms can be like tearfulness, decreased appearance, social withdrawal, decreased talkativeness, brooding, self-pity, pessimism, lack of reactivity are the manifestations, or what you can call as signs of impending psychological depression. And they manifest in terms as somatic symptoms, which the patient presents to the OPD with change in appetite, weight, sleep disturbance, fatigue, loss of energy, diminished ability to talk or concentrate, indecisiveness, etc. The common antidepressants that are used in our setup are amitriptyline, duloxetine, etc. Duloxetine is usually started in the dose of 30 mg, and 30 mg to 60 mg twice daily can be given. Also, sertraline, very commonly used antidepressant, can be used in the doses of 50 to 200 mg. And coming to the psychostimulants, the modafinil is a drug which is used to reduce the daytime sleepiness and can improve the psychological symptoms. Can be used in the dose range of 50 to 400 mg. So coming to neuropathic pain, neuropathic cancer pain occurs as a result of peripheral nervous system and CNS mechanism. It is a consequence of, it can be because of the direct infiltration of the tumor, or because of the tumor effects on the structure near the nerve tissue, inflammatory and other biochemical processes that can affect the neurological activity, neurotoxic effects of the treatment on the neoplasm. So the signs in which neuropathic pain can present are dysesthesia, paresthesia, hyperalgesia, hyperpathia, hypoesthesia, allodynia, numbness, and prolonged after sensations. So the various neuropathic pain syndromes secondary to the cancer treatment are chemotherapy-induced neuropathy. CIPN is a very vast entity. It can be a big one-hour topic in itself. Can be because of the drugs like cisplatin, oxaliplatin, etc. Cranial neuropathy is when there is a compression on this cranial nerves, and jugular foramen syndrome is commonly seen. Complex regional pain syndrome, type 1 and type 2, and plexopathies of brachial plexus, lumbosacral plexus, radiculopathy, etc. When all the three meninges are involved, it can manifest with leptomeningeal disease, or there can be neuralgia post-herpetica and radiation-induced plexopathy, post-surgical pains, which is post-surgical procedures, which are common for the spectrum of audience here, the onco-anesthetists, that they may have phantom pain, post-mastectomy pain, post-thoracotomy pain, radical neck dissection pain, neuromalformation, etc. So the common anticonvulsants which are used in the regular practice of a cancer pain clinic usually are gabapentin. That is what we are using very commonly. The doses start from 300 mg and can go till 3600 mg. And dosing interval, usually we start at bedtime to till 4 times daily. Sedation is a common side effect, and the mechanism of action is because of the inhibition of the calcium channel and reduced influx. And neuropathic pain, antidepressants, they play a very, very important role. Commonly used antidepressants I have mentioned that it is amitriptyline is a very commonly used antidepressant in my practice. We start with 10 mg and can go. I have not gone till 200 mg till now, but yeah, we definitely start having good effects when we start with the lowest dose itself. Duloxetine, as I have already mentioned, duloxetine is also commonly used, and it is used in the dosage range of 60 to 120 mg daily. And local anesthetics, we do give infusions of xylocard, ketamine on a regular basis. We have an ongoing thesis study by one of my resident who is doing a comparison between xylocard and ketamine for refractory cancer pain. So they definitely have results, along with GABA agonists like baclofen, steroids like dexamethasone, another novel drugs like clonidine, tiazinidine, etc. So coming to the breakthrough pain, so the pioneer study of breakthrough pain defined breakthrough pain as a transient increase in the pain intensity from a baseline pain of moderate intensity in patients on regularly administered analgesic treatment. These patients, they will have their background pain control, but suddenly they may have spurts of pain. So there are three categories of breakthrough pain. That is volitional, which is predictable. Incident pain due to movement or other maneuvers. When the patient's baseline pain is controlled very nicely, but the patient has to get up from the bed and go to the washroom, and or the patient with CA anal canal, he has a bad experience of going to washroom, because after going to washroom, he'll have a severe pain. So this is predictable and volitional, that a particular activity is stimulating their breakthrough pain. There is something called non-volitional or unpredictable breakthrough pain. It can be of unknown origin. It can come without any reason, suddenly on a background of baseline control pain. Or there is something called end of dose failure or insufficient background analgesia. It can happen, let us say, every 4th hourly, the patient is taking oral morphine. But by the end of 4th hour, if the patient is not taking medicine, and if he forgot to take medicine, by the right time, he will be having sudden pain. So that is called as end of dose failure. So this is a graph. This graph shows a well-controlled background pain with intermittent pain peaks. Here is a graph of uncontrolled pain, and upon that, there are peaks of pain. So, and here C is changes in the pain intensity of both basal analgesia and breakthrough pain after optimization therapy. So here there was an uncontrolled pain. After optimization of therapy, he had well-controlled pain in intermittent breakthrough pains. So we need to, for the treatment of breakthrough pain, we need to optimize the basal treatment, and non-opioids like NSAIDs, antidepressants, steroids have to be given to improve the basal analgesia and limit the occurrence of breakthrough pain events. Sometimes taking a call about intrathecal delivery of a combination of opioids and local anesthetics can be done on case-to-case basis. So usually in our setup, we manage the breakthrough pain with oral morphine and transmucosal fentanyl. Sometimes if the patient is admitted in the hospital, we can go for a trial of intravenous morphine. So peaks of plasma concentration of oral morphine. This is a graph showing the peak of plasma concentration of. So after 120 minutes, transmucosal fentanyl, it gets absorbed fast and gets resolved fast. So this now we'll discuss about bone pain. So bone pain occurs in approximately 60 to 84% of metastatic cancers, and mostly from the cancers like breast, prostate, lung, thyroid, and kidney cancer. Approximately 70% of the patients with bone mets, they develop pain. So in addition to pain, metastatic disease can result in immobility, frequent hospital admission, pathological fractures, metabolic complications like hypercalcemia, etc. So bone pain syndromes can be continuous, incident, mixed bone pain and neuropathic pain, and mixed bone pain and visceral pain. The treatments of bone pain is like we say that opioids are not very good choice for the treatment of bone pain, but opioids along with a background of other drugs like NSAIDs, corticosteroids, and combined with a cancer modifying treatment like radiation therapy, sometimes to reduce the bone turnover of calcium with bisphosphonates, all these have a role. And it's very common in a cancer setup that we see patients with bone spinal meds, they are posted for surgeries like vertebroplasty, kyphoplasty, etc. So all these are treatment modalities for bone pain. So we often see patients being treated with bisphosphonates, and once zoledronic acid or these drugs are given, the approximate time to first relief is approximately 1 week. So we do not expect immediate results. Immediate results are seen only after surgery like vertebroplasty and kyphoplasty, but even then they have post-operative pain. So we need to be patient while managing with these modalities. Opioids, yeah, as I've said, that regular administration has to be done, but they are not a very good choice. We need to consider adjuvants like bisphosphonates, NSAIDs, corticosteroids while we consider along with opioids. So also we need to manage the side effects of opioids. So now coming to last few slides, hospice practice and institution-based palliative care. Cancer pain management should be integrated into the hospice practice and institution-based palliative care programs. Whenever there is a non-responsive patient, and assume that there is the patient is suffering with pain. We need to do a caregiver interview, identify the patient behavior concerning for pain based on the interview, and we need to examine and treatment for any potential problem. If there is an improved behavior, that's well and good, but there is no improvement of the behavior, we need to give a trial of analgesia. And after the caregiver interview, there are no behaviors of the concern identified on the interview. We have to examine for causes of pain, and we find any physical concerns of pain, then we need to treat those underlying physical concerns. And if there are no physical concerns, it's well and good. So there is an important role of caregivers, that they are very important persons, and that they are the persons who relay information most of the times, because the patients are in severe pain or they do not wish to communicate. Then caregivers play a role in assessing and reporting pain, managing high-tech treatments, filling and refilling prescriptions, administering pain medications, promoting medication compliance, providing non-drug interventions, etc. The caregivers are always there along with the patients in Indian setup with a very strong family values. Their quality of life can get impacted, and there can be impacts on their physical, psychological, social, financial, spiritual impacts. So disease trajectory, adaptational tasks are not going much into these things. So coming to the take-home message, tumor-related pain management is multimodal, multidisciplinary, not only the single stakeholder of, it's not entirely the responsibility of the pain clinic physicians or the palliative physicians, but the role of onco-anesthetists, medical oncologists, surgical oncologists, radiation oncologists, psychiatrists, physical medicine and rehabilitation specialists, spiritual counselors, social workers, all of them, nurses, all of them play a very important and key role. So we are mostly dependent on the epidemiological studies. Till now, the data which is available, which we have presented, are from the Western countries. So there is a lot of scope for epidemiological studies in India. Let us say the incidence of cancer pain in patients with head and neck cancer. Multicentric study can be done, and at what stage of presentation they have presented, and how much is the prevalence of pain at the time of presentation. So lots of studies can be planned in this, but again, the stakeholders in these studies start from the surgeons, from the medical oncologists. So we need to involve multiple people and to move ahead. Our goal should be to make the patients pain-free. So these are the references, and thank you.
Thank you, Praneet, for this talk, actually, to take it forward. And I think it was some technical problem, some connectivity problem with Dr. Ahirup. He has made the slide, and Praneet has nicely taken care forward. Thank you very much. Any question? You can take it. Ahirup is now online.
Ahirup, are you online?
Are you there, Ahirup? Anyway, you can take the question answers, and
yeah, I'm looking in the chat box, man.
I also can't see any question answer.
Till now, no questions there.
No question.
So one important thing which I wanted to say is pediatric pain assessment. Pediatric pain assessment is a different thing that we need to know, that the scales like Flack scale, Wong-Baker Faces scale are available, and Faces pain scale are available. We generally do a mistake that we do Faces pain scale in children less than 4 years. Faces pain scale is meant for children within the age limit of 4 to 18 years. Flack scale can be used in children between 2 months of age to 7 years of age, whereas Wong-Baker Faces scale can be used in children 3 years and above. If the child is a neonate, there is something called NPAS, neonatal pain assessment scale. So this is one thing, and pain assessment scale we didn't discuss in detail because of the lack of time. So one thing is there are unidimensional scales like numeric rating scale, VAS scale, etc. in the adults. And there are multidimensional scales as well, like brief pain inventory, which we have discussed, McGill pain questionnaire, which we haven't shown in the PPT.
Okay. So I know, Praneet, you are doing pain practice very well in cancer patients. So yes, I just want to like to know your experience with methadone in cancer pain.
All right. Methadone is a drug which we have been using since past 2 years. So methadone we consider to the patients in whom compliance issues are there with, let us say, they are not using oral morphine because it is making them quite nauseous. Or the, am I audible?
Yeah, you're audible.
Yes. So we are not using we are not using methadone in certain patients in whom the education status of the patient is not good, because methadone can cause sudden QT prolongation, sudden cardiac deaths. So one thing is we need to have a motivated caregiver. First thing. And second thing, we are considering methadone syrup in those patients in whom morphine requirements are going up, or the patients having severe neuropathic pain component. So in those patients, we are using methadone. We do calculate we do evaluate their baseline electrolyte status, and then check a baseline ECG, calculate the QTC interval, and then we are evaluating the drugs which the patient is taking along with methadone previously, whether they are on any other drugs which are likely to prolong the QTC interval, like antidepressants, etc. And then we consider the trial of methadone. There are two ways which we can do methadone titration in an IP setup. One thing is 3-day switch method or stop and start method. And once the morphine requirement by morphine titration we have started, and something called oral morphine equivalents. Once, let us say, the patient is settled on 1 ml of oral morphine, 1 ml of IV morphine per hour. So the 24-hour requirement is 24 mg, and per day, if we calculate the oral requirement, it is 24 into 3, that is 72 mg. So the oral morphine equivalence is less than 200 mg per day. Then we can convert the patient using 1:10 conversion. So 72 mg of morphine will be equivalent to 7 mg of methadone. So this 7 mg of methadone can be divided in 3 divided doses. Like that.
Okay, so did you encounter any complication with methadone use in your patient?
Touchwood, madam, we have done almost 200 patients till now on methadone. It is publicized to be a very careful drug, has to be done under monitoring. But till now, actually, apart from the expected things that along with the disease progression, patients have succumbed. But under our supervision, exclusively, we haven't noted anything which is very specifically due to methadone.
Okay. Any other question in the chat
It's
box?
a safe drug.
Am I audible, ma'am? Am I
Yeah,
audible?
you are audible, Dr. Ahirup.
Okay. Sorry for the glitch.
Yeah, thank you. No, it's not a problem.
But I can't see Dr. Ahirup. Can't see you.
Still a problem, ma'am. Only the audio
Okay.
is.
Okay, all right. So if you want to give your comments, you can give your comments.
Oh, as sir said, my
Okay. So no other question I can see. I'll just ask another my doubt. I just want to clear from Dr. Parneet. What about
Yes,
your
ma'am.
practice in hematological malignancy?
Oh,
Pain
great.
in hematological malignancy.
Yeah. The commonest pain that we encounter is in the post-transplant patients, post GCSF injections. There can be flare-up of pain because of the bone marrow expansion. This is one thing. Hematological malignancies, because they go for extensive chemotherapies, they may develop oral mucositis, and oral mucositis related pain can be there. Sometimes when the patient undergoes a graft, sometimes they develop something like a graft versus host disease. And here the ball game becomes very complicated, that they have unexplainable abdomen pain. We had a patient who had unexplainable abdomen pain. We did CT abdomen, etc. And when the physician had a suspicion for graft versus host disease, he took a biopsy of a particular region, and then it was confirmed to be GVHD. So the assessment and evaluation is a complex one in these hematological malignancies. They may present with lymphadenopathy related pain, splenic enlargement related pain, multiple issues can be there. And because of the chemotherapy, many people develop chemo-induced peripheral neuropathy, and chemo-induced peripheral neuropathy related numbness, pain, and all these things.
Okay, so basic your pain management is almost similar, same like other malignancy, or
yes, madam. But determining the etiology for the pain, why the pain is happening in a hematological cancer, is actually there itself lies half of the work. And if it is done, next half will be easier. So coming to a conclusion is difficult. When it is very much obvious, like an oral mucositis, it is not very difficult. But unexplainable bone pain, we schedule the patient to bone scan, nothing comes into that. We suspect something in the viscera, and viscera is absolutely clean. And until and unless the patient is excruciating pain and we do a biopsy, came out to be graft versus host disease, which is the nightmare for the bone marrow transplant physician. So diagnosing and knowing the right cause is the most key thing that has to be done.
yes.
Sir, may I ask a question? Sorry, if
Sure,
Yeah.
please.
yeah. So, sir, in like the bone pain, maybe. So, is it? I think the more neural structures are more for the marrow than for the cortex.
I
In
would feel it is more for the cortex, because cortex is more sensitive. I mean, I need to check back on this
so
question.
okay, so the maybe because of the expansion that might lead to the pain.
Yes, compression of the cortical structures.
Right.
The more marrow is expanding, and it is causing in turn, because there is no space, it is compressing on the cortical structures, and the cortical structures are causing pain.
Right. Right.
So, any comments from the attendees or anything? No,
Till now,
reaction,
not a single one.
no response I can see from the attendees. They're listening, or
Maybe
any
that's
comments?
not their area of interest, not their area of interest, probably.
Yeah, maybe. But
Cancer
I think
pain management, when I was doing my DM in onco anesthesia, cancer pain management didn't draw to me initially, but I developed a liking to it in my second year of my DM. So it takes time to kick in.
yes. So, but many people are there who are practicing pain actually. So, any comments from them? I can see in the list, attendees list, people are there
I
who are
can
practicing
see
pain.
Shikar.
Yes.
My dear friend, please share your experience with sublingual buprenorphine. Talk of the devil, I got a comment from him.
Yes, that's why I was wanting, because I know people are practicing pain in there in the attendee list. So, any comments? Sir? Okay.
Hi, Shikar. So, yeah, we have experience with managing sublingual buprenorphine, but I am not doing it because I feel transmucosal fentanyl is a very safer thing. Even though it is slightly expensive, I still want to put my patients on transmucosal fentanyl than sublingual buprenorphine, because there is a sudden onset of vomitings, giddiness in quite a few patients whom I started. But yeah, this is only my experience on a few subset of patients. Has to be validated on a bigger scale. And there was a proposal from you last time that we can start doing something multicentric on this. Yeah, we will do. I'm open to that.
Yeah, I think so. You should, whoever are practicing pain, all of you should take up this sort of thing, new things, and see what is the our data. You should collect our data actually, what you're doing. So first we can collect the data, and based on that you can do some other trial. So all our young pain physicians across India, you can take up this sort of research work.
Sir, even with transdermal buprenorphine patches, also we do have nausea, vomiting.
Yes, we do have nausea, vomiting even with transdermal buprenorphine patch, but the sublingual buprenorphine, what happens is there is a sudden surge in the plasma levels of buprenorphine, isn't it? So
Right.
that would actually cause the patient sudden onset of giddiness and vomiting. Whereas with transdermal buprenorphine patch, there is slow onset and build-up of the drug. So it will, patient will have some time to adjust.
Right.
So, so I don't find any other comments or questions in the question box. I think other experts are there. Sohan is there.
Sohan sir must be in the flight.
Sohan is not there. I think he must be in flight. So I think you can call it a day. So,
sure, madam. Thank you very much for being
it
there.
was a nice discussion, and again, thanks a lot to Praneet that we could complete the session. Thank you so much.
Sorry for the glitch.
No issue. It's a technical problem. Technical problem probably can happen. So thank you so much. Thank you to all the attendees and also Dr. Ahirup and Dr. Praneet. Thank you very much.
Madam. Thank you, Dr.
Thank you, ma'am. Thank you, sir.
Thank you, Josna. Thank you very much. Thank you, everyone.
Good night.
So with that, we come to the conclusion, everyone. Thank you so much for extending us the opportunity to host the session today. I hope you all had a seamless experience with us. So with all your due permission, let's call it a day, and we'll soon meet on this exact platform. Thank you so much, and bye to all of you.